That answer. So good evening and welcome to yet another exciting session of the Venad Guild of Psychiatrists online academic series. Today we have the second session on phenomenology, disorders of possession and content of thought. So our speaker for tonight is no stranger to you, and I'm excited to introduce you all to him because today our roles have reversed. It is usually Sir who introduces me to you all, but today I get the opportunity to introduce you to him. He had already presented a topic which is treatment resistant depression, which unfortunately I could not attend that. So today I get to introduce my favorite teacher. So let me welcome the renowned psychiatrist of Kerala and president of the Venad Guild of Psychiatrists, Dr. Arun B Nair. Sir is a professor, Department of Psychiatry, Government Medical College, Thiruvananthapuram, and honorary consultant psychiatrist at Sri Chitra Tirunal Institute of Medical Sciences and Technology. His Sir's achievements are many, and his knowledge is not just limited to psychiatrists. Not just limited to psychiatry. It goes over and beyond the scope of psychiatry. You have any doubt under the sun, just give him a text and he'll reply. Sir is also an excellent orator, and that is something I look up to Sir for. And he is author to more than 29 books, including The Miracle of Human Bonding, Live, Learn, Look Bright, and has authored chapters in 5 textbooks of psychiatry. So he has conducted several awareness programs. He has mentored civil service aspirants, and he's a humongous media presence, including TV shows, news channels, magazines, radio. He's also a recipient of several awards, including Vocational Excellence Award of Rotary International, Manava Seva Ratna Puraskaram, IMA Media Award, etc., and is also certified by the Asia Book of Records for the largest suicide prevention radio program across our nation. So, with a great pride as a student, I would like to welcome Sir to this session, and over to you, Sir, to present the topic.
Thank you. Thank you very much, Nino, for that very kind words of introduction. It's always a pleasure to hear such words from your students, and especially words from a very brilliant young psychiatrist like Dr. Nino means a lot. So let me start sharing the screen. Hope my slide is visible to all of you.
Yes, sir. Sir, mute ആണ്.
Okay, hope I am audible now.
Yes, screen. Okay.
Okay. Last week, Dr. Indu V Nair had given a wonderful talk on stream and form of thought abnormalities, which was much appreciated by consultants and postgraduates from all over India. I've been receiving so many messages appreciating that talk and asking for recordings of that talk from different parts of the country. And I'm trying to do the second part of that presentation. Today's topic is disorders of possession and content of thought. For the newly joined postgraduates, thought is one of the major mechanisms by which we understand and analyze the mental state of a person sitting in front of you. And there are 4 subheadings under which thought is analyzed. Number 1 is stream and flow of thought, which has been discussed in last week's session. Second is form of thought, that is the structure in which thoughts are organized and arranged. Third one is possession of thought. Possession means actually our thoughts are our own. It is under our absolute control to the best of our knowledge. But there can be certain situations in which you feel that your thoughts are no longer under your control. They are either intruding into your mind and creating distress, or are getting taken away from the mind by some external agency. All such weird experiences can happen. So those are the disorders of possession of thought, we shall discuss in a little bit detail. And next is disorders of content of thought. Content of thought means what is the material which is involved in thought, what is the message which is conveyed in that thought process. So with this brief introduction, let us go to possession of thought disorders. So as I've already mentioned, possession means our thoughts are absolutely under our control in a normal situation, normal circumstances. So, possession of thought disorders include obsessions and compulsions, number one, and thought alienation phenomenon, number two. I'll explain them in little bit detail in the coming slides. So, what do you mean by obsessions? Obsession is a word which is very commonly used in literary parlance. We say that a boy is obsessed with a girl, a person is obsessed with his work, etc. So there is a commonplace usage of obsession. So the meaning of the word obsession, which we understand from journalist parlance, is that someone is focusing intensively and excessively on something, that is obsession. But in psychiatry, obsession is slightly different from that. So Fish psychopathology gives the definition of obsession as follows. Obsession is a thought which persists and dominates an individual's thinking, despite the individual's awareness that the thought is either entirely without purpose or else has persisted and dominated their thinking beyond the point of relevance or usefulness. So, any thought which is persisting and dominating your cognitive system, even after the person knows that it is without purpose, or even when he knows that it has persisted and dominated beyond the point of its significance. So we can explain the term obsession in a little bit more greater detail with a more simple definition. An obsession is a repetitive, intrusive, unpleasant thought, impulse, or image which the person himself recognizes as illogical or irrational, but still is unable to resist. So, obsessions can occur in three formats. It can be a thought, it can be an impulse or an urge to do something, or it can be an image. And there are three qualities for obsession. It should be repetitive in nature. It should be intrusive, that it comes into your conscious awareness when you don't want it to come or when you are not welcoming that thought. And it is unpleasant by nature. And the person himself knows that the content of that obsession is illogical, irrational, but still he is unable to resist. And the content of the obsession causes great amount of anxiety, and sometimes it even creates great amount of guilt. For example, a person who is extremely prudent, he is getting sexual images of his own mother or his own sister. It creates great amount of guilt. A person who is God fearing is getting blasphemous images in his mind. It produces intense anxiety. So it is a content which creates either anxiety or guilt, and it appears against the will of the patient. It is not something which is voluntarily created, it appears against the will or desire of the person. So these are the qualities of what you call an obsession. So let us discuss about what is meant by compulsion. So whenever a person is getting an obsession, an obsessional thought, what happens is that there is intense anxiety. And when there is intense anxiety, you try to relieve that anxiety somehow. And what do you do to relieve that anxiety? You either do certain repeated actions or you do some repeated cognitive processing. And that is exactly what is called compulsions. So, compulsions are mental or motor acts done by a person to relieve the anxiety associated with an obsession. So, like for example, you are having an obsessive thought that there is some dirt in your hands. You know that if you wash your hands with soap for 20 seconds, it'll be clear. But still, you are getting an intrusive thought that still is the dirt remaining? Is the dirt completely cleared off? Is there a possibility of some soap resistant virus getting into your hands? You know that it is illogical. It cannot happen like that as per current scientific knowledge, but still that thought intrudes and you become unpleasant, you become anxious. To relieve that anxiety, you do repeated washing, and that repeated washing is what is called compulsions. Always, compulsions need not be motor acts, it can be mental acts also. Like, for example, you go to a church or a temple and you get a blasphemous image of you having a sexual act with God, for example. You feel intense guilt, you feel intense anxiety. And to relieve that guilt, you chant certain prayers 101 times or hymns a fixed number of times. So nobody is seeing you doing anything. You are sitting still or standing still doing nothing, but you are doing this mental compulsions. So that is about compulsions. So, what are the common types of obsessions and compulsions which we see in clinical practice? The commonest type of obsession which we see in our part of the world is obsession of contamination. Obsession of contamination means you feel that there is some dirt in a body part, your hand or any other part of the body. You feel very anxious because of it. You try to wash it, but still, after some time, that thought process comes again. You fear that that dirt may go into your body along with food and create some sickness, and you may fall ill or even die. And all the symptoms of anxiety, including palpitation, restlessness, everything comes in. And the anxiety becomes so intense that in order to relieve the anxiety, you're forced to go and wash your hands again. So that repeated washing is the compulsion. So don't think that this compulsion will be limited to washing your hands for 5 minutes or 2 minutes or anything like that. It starts like that. But gradually, if that obsession is untreated, unaddressed, it can extend to such a level that it can take a lot of your time. Like, for example, we had a patient in our own OPD who was referred from the Department of Dermatology. He had gone to dermatology because his skin was peeling off. And on listening the history, the dermatologist understood that he needs a psychiatric consultation first of all, and he was referred to us. The thing was that he had the same symptom 6 years ago during the beginning of the COVID, because there was a lot of news through the media regarding how COVID virus is spreading and how you should keep your hands clean and things like that. So it got converted into a repetitive, intrusive thought. So the parents thought that it was good. He was remaining clean. But that cleanliness extended beyond a certain level to reach a stage that over the last 6 years, now he is taking 8 hours of time to take his bath. So he has divided his body part arbitrarily into 10 different areas. One area, he has to apply soap in the right hand direction 5 times and then left hand direction 5 times. Then only that part becomes clean according to his conviction. But when he is trying to apply soap, when 3 times is finished, he becomes confused whether it is actually three or two. He loses his count. And once he becomes confused like that, he has to start over again, right from the beginning, right from the beginning. So nowadays, what happens is that if he wants to go to school, he should go to take bath right from midnight. Then only he can get out of the bathroom by 8 a.m. in the morning and go to school. So this has reached to a state where is unable to go to school and is sitting at home for more than 2 years now. That is the extent to which this obsession of contamination can go and impair the quality of life of the person. The second type of obsession is what is called pathological doubt. Pathological doubt means you do a particular act, but you are not sure whether you have done it correctly. So, what happens is that you want to check it over and over again. Like, for example, you have bolted the door, you go to your bedroom, you have a doubt whether you have bolted the door of the living room correctly. And when that thought process comes, you feel anxious. If I haven't bolted the door correctly, there's a possibility of some thief entering my house and robbing my house. You become anxious. And when the anxiety peaks, you go out and check it again. Checking once in a while is okay. Maybe one time or twice is okay. But imagine a situation where you have locked your home and you are going to your workplace, you get into a bus, and midway on the road, you get an intense obsessional thought whether you have correctly locked the door. You get out of the bus, you travel all the way to your home again and recheck again. That is going to affect the day to day functioning of your life. So, that is pathological doubt. Every year after the UG NEET and entrance examinations are over, we get a handful of kids having a particular kind of pathological doubt. So there used to be this habit of blackening circles as part of the MCQ exams. So this particular boy, he has read the first question. He knows that the answer is option C, is blackened option C. And then he reads question number two. Then he suddenly gets an obsessional doubt whether he has rightly answered question one, whether it is actually C, whether he has encircled the entire bubble, or whether the blackening has gone outside the margin, will it end in a negative mark? He goes back and checks. So this boy, extremely brilliant student, he is unable to answer even 10 questions out of the 120 questions he has to answer. Such kind of things happen. And there was this very interesting case which was referred to us from a principal of a big school in Trivandrum last year. The principal had written a letter to us that this boy has learning disability. Kindly issue him a disability certificate so that he can get the educational benefits for exam. So his parents also were telling that he is unable to complete the exam, and that is his problem. They asked him, does he have difficulty in writing or reading? Parents said, no, the problem is that he keeps on striking off whatever he has written. I made him write different words, both in English and Malayalam. I gave him some of the toughest words. He was answering even those things very correctly. I asked him to write the word Drishta Dymnan in Malayalam. He even correctly wrote it. But what happens is that after he has written, he observes what he has written for a second, then he strikes it off, writes again, then strikes it off. Again, strikes it off. 5 or 6 times after that, he just tears the paper and throws it away and takes another paper and repeats the same ordeal. This is again an example of pathological doubt. He's having an obsessional doubt whether he has written the name correctly, written the word correctly. He feels anxious that there is some mistake. He wants to rectify it, and he keeps on repeatedly doing it. So, this has led to an impression in the mind of the teachers that this boy was suffering from probably learning disability. It was not, it was just an obsession of pathological doubt. Third one is obsession of symmetry. You want everything to be arranged in an order. Like, for example, on your table, there are two rows of books. One row is taller than the other. You rearrange it so that both of them become of the same height. So, this is what is called rearranging compulsion, which is the obvious result of obsession of symmetry. Then we get sexual obsessions. For an adolescent boy or a girl, a sexual imagery may be a pleasurable experience. But what if you get a sexual imagery of your own mother, your own father, your own brother, your own sister? You feel guilty about it. You feel guilty about it and you become intensely anxious whether you have actually done something in that direction, even when you know 100% that you have not misbehaved with any of them at all. But that anxiety peaks to such a level that you goes and ask reassurance to them. You go to your sister and ask her, have I misbehaved with you? When she says that no, you haven't, you become relieved for the time being, but you go back and after some time again you get the same obsession. So that is sexual obsession, and reassurance seeking is the compulsion. Blasphemous obsessions. Whenever you pray, whenever you go to a temple or a church, whenever you see an image of God or anything which symbolifies God, suddenly you are getting some images in your mind of you abusing God, or some sexual image involving God, or you have an internal urge to utter an abusive phrase. But you do that. Once you do that, you feel intensely guilty because you have done mischief with God, which is an unpardonable error according to religious beliefs. So, what do you do to relieve the anxiety and guilt associated with that? You pray repeatedly, you chant hymns repeatedly, you keep on silently praying repeatedly over and over again. And also, there is obsession of ill health, also. Like, for example, I can give you a person when he walks on the road, he sees some dog in his visual field. Then he has a doubt whether the dog has licked his foot, the dog has bitten his leg, or if you ask him again, he say that no, the dog has not come anywhere near me, but there is a possibility that the dog has urinated in front of my house and I might have touch the urine of the dog, which can lead to transmission of rabies virus and things like that. And you feel intensely anxious. The scenes of Mrigaya film where Bhiman Raghu dies out of rabies intrudes into your mind. You become very, very anxious and you finally go to the nearest hospital and get vaccinated. So after vaccination, you ask the doctor how long the protection is available. The doctor gives the clear answer for that. But the very next day, you go to another place and you see a dog somewhere in the vicinity. You feel anxious. You go to another hospital and get vaccinated again. So repeated vaccination, repeated health-seeking behavior, etc. All these are different kinds of obsessions and compulsions which we see in our daily clinical practice. So, apart from obsession, now we come to the second possession of thought abnormality, that is, thought alienation phenomenon. So, thought alienation is a component of the first rank symptoms of schizophrenia as discussed by Kurt Schneider, the Schneiderian first rank symptoms. So, about Kurt Schneider, a word about the history of schizophrenia. You know, in 20th century, when medications for mental illnesses was not identified, the early researchers had an opportunity to observe the natural course of mental illnesses. And many of the European researchers had an opportunity to learn the natural course of various mental illnesses. The first out of that was Emil Kraepelin. Emil Kraepelin observed people with mental illness and identified that there were two different kinds of mental illnesses. One group in which people used to be overactive, over energetic, excessively happy for a period of time, then reduced activity, sadness, not going to work, crying spells, sometimes even suicidal ideas. So he identified that there was mania or overactivity and depression or reduced activity. And he named that condition manic depressive illness or MDI. And there was another category of people who were having illness beginning during their adolescent years, continuously present, the symptoms including fears, suspiciousness, hearing of voices, and things like that. Over a period of 10 to 15 years, the illness worsened and cognitive deterioration set in to such an extent that the higher mental functions, including memory, orientation, everything came down slowly. And around 30, 35 years, they reached a stage where the condition was similar to that of dementia. Their higher mental functions had almost completely deteriorated. So it was dementia which was happening at a young age, and Kraepelin named that condition dementia precox. And this classification of mental illnesses into manic depressive illness and dementia precox, this is the first classification of mental illnesses in the history, and this is called Kraepelinian dichotomy. Later, Eugene Bloiler, another researcher, he renamed this dementia precox as schizophrenia. Schiz means split and phrenum means mind. And Kurt Schneider was the person who described the first rank symptoms. And thought alienation. Thought alienation means your thoughts, which are supposed to be your own, under your absolute control, become alien to you, become no longer under your control. Or rather, they are controlled by some external agencies which cannot be explained in logical terms. So there are three types of thought alienation phenomena. Number one is thought insertion. Thought insertion means someone is inserting thoughts into your mind. These thoughts are not mine. Somebody is inserting these thoughts into my mind. How? I don't know. Some people say that it is using certain instruments. Some other people will say that it is using black magic. Anyway, these are not my thoughts. Somebody is introducing it into my mind. That is thought insertion. And this thought is held with very strong conviction. Is 100% sure that the thoughts are being inserted from outside. Second is thought deprivation or thought withdrawal. The latest issue of Fish calls it as thought deprivation, but classically we used to say it as thought withdrawal. The thoughts from your mind are being taken away by somebody, by some external agency. I don't know how, but the thoughts are getting out of my mind. And third, probably the most distressing one, is thought broadcasting. Thought broadcasting means whatever you think in the privacy of your mind is being known to others without you telling them the same. Something you think in your mind is being known to others without you telling them. That is thought broadcasting. It's a very disgusting, very distressing symptom because we had a patient recently, an 18-year-old boy who had tried to hang himself. He was admitted in the medicine ward. The reason for his attempted suicide was not known to anybody. He refused to reveal anything to the doctors who were treating him, and his parents had no clue regarding why he has done this. Finally, he was shifted to our ward, and on lot of prompting, after a couple of days, he opened up his mind. He said that over the last 6 months, he is getting a thought that his private thoughts are being known to others. When he goes to college, he's in the first year of college. When he goes to college, when he sees some of his friends smiling, he gets a feeling that probably they have understood my thought, my fantasy, and they are laughing at me. So, what triggered the particular attempted suicide was that there was a girl who was staying opposite to his home, and he had a crush on that girl. The girl was a good looking girl, according to him, and he used to have some sexual fantasies about that girl also. One morning, he had gone to a shop to buy something on a Sunday morning. He had returned, and this girl was seen walking opposite to him. The girl smiled at him. It was a very friendly smile, obviously, but suddenly he had an idea that the girl has understood my sexual fantasies about her. How can I face her ever again? And he went to his home and tried to hang himself. So, that is the extent to which thought broadcast can produce distress in human beings. And ego syntonicity and ego dystonicity, these are two terms which you should understand. Ego syntonic means something which is in accordance with your ego. An experience is described as ego syntonic if it is consistent with the goals and needs of the ego or consistent with the individual's ideal self image. So, whatever you think about yourself, a thought process which is in accordance with that is called an ego syntonic thought. While ego dystonic thought is a thought which is not in accordance or not consistent with your own self image. The distinction between ego syntonic and ego dystonic phenomenon is not absolute, and the clinical picture may sometimes be complicated by primary or secondary delusions, the details of which we will come to subsequently. And sometimes even the mood state of the person may influence whether it is ego dystonic or ego syntonic. But however, we can say that if the individual has psychosis and an individual with psychosis develops an insight into his symptoms, the experience of thought alienation may be ego dystonic and it may be distressing for them. But if there is no insight, such distress may not sometimes happen. Now we come to disorders of content of thinking. So, when we examine disorders of content of thinking, delusion is one thing which is very commonly discussed. Then there is something called an overvalued idea, or sometimes there is another term called delusional idea also. Classification of delusions are there: primary delusions, secondary delusions, and something called systematization, which we shall discuss in little bit detail as we proceed. So, also, what do you understand by the term delusion? A delusion is a false, unshakable belief which is of morbid origin, which is held with very strong conviction, and which is persisting even after providing evidence on the contrary, and which is out of keeping with that person's cultural, educational, religious, spiritual background. So that is delusion. So delusion fundamentally is a false belief. Of course, I may think that I am the best clinician in the world. It's a false belief. It's an unshakable belief. It is held with very strong conviction and it is of morbid origin. And more importantly, it does not go away even after you provide an evidence against it. I say that I am the president of India. You are giving me a photograph or a video of the actual president telling me that This president is not you, it is a female, but still I refuse to believe that. And it is out of keeping with my cultural and educational background. A person who belongs to a tribal community, he wakes up in the morning to find that his son is suffering from fever. It has been culturally trained to them that probably fever is the sign of wrath of gods. So we have to please gods. So he is arranging a spiritual ceremony to appease the gods. But a person who is working as an engineer in Technopark in Trivandrum, who used to take treatment for all illnesses, still now wakes up one fine morning and tells that my son is having fever, seems to be the wrath of God, I am going to conduct a homo. Then you need to consider it as a delusion because it reflects a change from his baseline cultural belief. So that is delusion. So delusion is a false, unshakable belief which is of morbid origin, which is held with very strong conviction, and it is out of keeping with the person's cultural, educational, social, spiritual background. So, what is meant by this overvalued idea? An overvalued idea is an unreasonable, rigid, intensely held personal belief. It's an unreasonable belief, it's a rigid belief, it's an intensely held belief, it's a personal belief which dominates the life of the person, the thoughts of the person, and actions of the person. Unlike delusion, these beliefs are not entirely detached from reality and may be shared by some others in his culture also, but they are held with excess intensity and poor insight. Like, the key characteristics of an overvalued idea is that it is a dominant idea. They consume the individual's life to a pathological degree. The difference between delusion and overvalued ideas is that individuals with overvalued ideas may acknowledge the possibility that this particular idea may be untrue, it may be false. But in delusion, they will never ever acknowledge that it is false. And how to distinguish this overvalued idea from obsession? The person does not fight against an overvalued idea. Instead, they will embrace, defend, and feel validated by that idea. But in the case of obsession, the person will fight with that idea. He'll try to throw it out. He'll try to push it out of his system. He feels distressed. So, an overvalued idea does not produce such kind of a distress. Rather, the person may feel, in unison with that idea. He may embrace, he may defend, or he may even validate that idea. Now we come to different types of delusions. Primary delusion, or sometimes called autochthonous delusion. So, primary delusions were previously considered to be experiences which were diagnostic of schizophrenia. But now it is recognized that such primary delusions can occur in other conditions also, which can include some organic conditions as well as in other psychotic illnesses like delusional disorder also. The essence of a primary delusion, which is also termed apophany, is that a new meaning arises in connection with some other psychological event. So a psychological event is occurring and a new meaning is arising in connection to that. Schneider in 1959 suggested that these experiences can be reduced to three forms of primary delusional experiences. They may be delusional mood, they may be delusional perception, and they may be sudden delusional idea. So, what is meant by delusional mood? Let us understand what is meant by delusional mood. In delusional mood, the patient has a knowledge that there is something going on around him that is concerning to him, but he does not know what exactly it is. Something is wrong, but I don't know what exactly it is. Usually, the meaning of the delusional mood becomes obvious when a sudden delusional idea or a delusional perception occurs. So, in a sudden delusional idea, as we call it, a delusion appears fully formed in the patient's mind, and this is sometimes known as autochthonous delusion. The form of this symptom is not in itself diagnostic of schizophrenia because sudden ideas or brain waves they can occur in individuals both with or without mental illness. In persons with depressive disorders or severe personality disorders also sudden ideas which are like delusions can occur, And sometimes some intense experiences can also happen, but often they are very short lasting. So, in delusional mood, what we have to keep in mind is that delusional mood is a condition in which it's a prodrome kind of a state where the person feels strange, something ominous is going on, some intense hidden personal meaning is there for certain experiences, and often it precedes a full blown psychosis. So, the nature of the experience is very unpleasant, something very uncertain is there, and you are not sure about what is actually happening. So, that is delusional mood. So, delusional atmosphere is also another term which is closely related to that. So, delusional atmosphere is also very similar to delusional mood when what is happening around you, the people around you, the movement of the people around you, the what they talk is something which is creating some confusion. You are unsure about what they are talking about, but you have a thought whether that they are talking something about you. And now, what is meant by this delusional perception? Delusional perception is attributing a delusional meaning to a normal perception. So, what is meant by a perception? Perception is the process of giving a meaning to a sensory experience. You are walking through the road, you see a snake. Seeing the snake is a sensory experience, but knowing that the snake is a poisonous animal, if you go near it, it will bite you, and if you get a snake bite, you can die. That is a perception. So, delusional perception means you are getting a normal perception. You go to a hotel and somebody is giving you some food, a whole basket of rice is kept, and to serve the rice, there's a spoon. And the spoon is a peculiar spoon in which a crown is also there embedded in the spoon. This is the example which is given in classical psychopathology textbooks. So, seeing a spoon with a crown on it is just a perception. A person can think that what a wonderful work of art it is. You can enjoy it like that. But suddenly you get a feeling that I have been given this particular spoon with a crown because I belong to the royal lineage. They have understood that I have got a royal connection. That is why they have given this particular spoon with a crown over it. This is called delusional perception. So, delusional perception is a phenomenon which has got something called two memberedness. The first member is the normal percept, and the second member is attributing or attaching a delusional significance to it. So, this is what is called delusional perception, and delusional perception is also among the first rank symptoms of schizophrenia, which were described by Schneider. And what is meant by this delusional memory? That is also another thing which we need to keep in mind. A delusional memory is a false, fabricated, or distorted memory which is held with absolute, unshakable conviction despite clear evidence on the contrary. It may be two types. It can be a fabricated memory, remembering a complex, entirely false event, like you were kidnapped when you were a child, were taken to a particular place, and things like that. It may be a fabricated memory. And the second kind is what is called distorted memory. Distorted memory means you are applying a delusional interpretation to a real neutral event. Like, for example, a neighbor came to your home and asked you, "How are you? How was your exam?" You feel that that particular gesture from the neighbor was actually an attempt to spy on you. He was trying to understand whether I was making money or whether I was having an affair with somebody. That is exactly the reason why he came in exactly at that point of time. So, delusional memory can be either a fabricated memory where you fabricate a totally false event which has never happened, or it can be distorted memory where you misinterpret a particular event, a neutral event, as something which is really, really pathological. And again, coming to the types of delusions, ICD mentions about delusions which are completely impossible and unbelievable in nature. So we use the term bizarre delusions to describe that term. So a bizarre delusion is a delusion which is impossible, implausible, and unbelievable. Asadhyam, asambhavyam, avishwasaniya. Like, for example, you are able to control the nature, like you are having supernatural powers. On hearing itself, you realize and recognize that it is impossible. Such a thing is unlikely to happen. So that is bizarre delusion. Classically, bizarre delusion was thought to be pathognomonic of schizophrenia, diagnostic of schizophrenia. But the newer classification systems have mentioned that bizarre delusion can happen in other disorders also, like delusional disorder. And non-bizarre delusions are delusions which are humanly possible, believable, logical up to a certain extent. Like a person telling that my wife is trying to mix poison into my food. It's a possible thing. It's a humanly possible thing. It's a non-bizarre delusion. But if the same person says that if I move my hand thrice, it'll start raining, it's a bizarre delusion because he means that he can control the weather or control the nature, which is bizarre. So bizarre delusions are impossible, implausible, and unbelievable. By non-bizarre delusions are plausible and possible delusions. So a list of delusions, the types of delusions, briefly mentioning them. Delusion of persecution, where you have a very strong feeling that somebody is trying to kill you, harm you, or hurt you, either directly or indirectly. Delusion of infidelity is otherwise called, Othello syndrome in some textbooks. It's a feeling that your spouse is unfaithful to you, is having illicit relationships, even though there is nothing to suggest that. Delusion of love means a person who is of higher pedestal, higher social strata, or a celebrity or someone is in love with you. It's otherwise called the de Clerambault syndrome. Grandiose delusion, where you feel that you have got excess amount of money, excess wealth, you have got great talents and abilities which actually you don't have. You have direct connection with God and things like that. Often happens in mania, but can happen in psychotic disorders also. Delusion of ill health or hypochondriacal delusions. They are also usually mentioned in the books of psychopathology, where you feel that you have got an illness which actually does not exist. So here, there are different grades to this thought process. There can be phenomena where people goes and visits doctors over and over again, complaining of back pain. Multiple investigations are done, but no organic cause is identified. Still, they complain of back pain. But reassurance that there is nothing wrong will give some amount of relief for a brief period of time. But after some time, it happens again. So, this is what is called somatoform or somatization disorders. Then there can be situations where another person can complain of, I doubt that I have got a cancer in my throat. I need an endoscopy. Once that endoscopy is done and that cancer is ruled out, the person is relieved for the time being. This is called hypochondriasis or illness anxiety disorder. Again, after a few days, it will come back and they'll go to another doctor. But in delusion of ill health, the person says that I am HIV positive. He has a whole list of investigation results which show that he is HIV negative. You ask him, you have went to multiple labs, and all the results say that you are HIV negative. Then he will have a conspirational explanation for that. They don't want me to identify that I have HIV positive. They want me dead. That is why they are manipulating the blood sample there and changing my blood sample with someone else's blood sample and giving false results. When you ask the question again, how is it possible that multiple labs, 25 labs, you have done investigations, all of them can do like this? Yes, my perpetrators, they have got influence over the entire humanity. They can do like that. So that is delusion of ill health. Then delusion of guilt. You feel that a normal act you have done is probably a crime and God has punished you for that particular act. That is called delusion of guilt. Nihilistic delusion, it's a delusion where you feel that a part of your body does not exist or that you don't exist. Classically happens in depression, but sometimes in psychotic disorders also. We had this particular patient who was refusing to take food because he said that his stomach is degenerated. So he doesn't have any stomach. So whatever he consumes is likely to go to his lungs. So he refused to take food. Delusion of poverty. An extremely rich man feels that he's poor, he doesn't have anything, and lives a life of misery. And of course, delusion of reference, where you feel that people are talking ill about you, people are talking bad about you, people are spreading rumors about you. All these are different types of delusions. And there is also something called delusional misidentification, which can happen. Delusional misidentification is a syndrome in which you misidentify one thing for another. One example is Capgras delusion, where you feel that a relative or a close friend is not that actual person, but an imposter with a physical resemblance to that person, and that person has a persecutory intent. That person has crept his way into my house with an intention of harming me, killing me, or raping me. So my wife is not my actual wife, it's an imposter with physical resemblance. My son is not my actual son, but it's an imposter with a physical resemblance. He wants to kill me. That is Capgras. Second is Frigoli delusion. So in Frigoli delusion, you feel that a persecutor is assuming different guises, different shapes, and different forms, and approaching you in different situations, different circumstances with an intention of killing you, harming you. You say that there is a magician who wants to kill me. He's assuming the shape of my father. He's assuming the shape of my teacher. He's assuming the shape of my psychiatrist, and he's trying to kill me. Actually, the Frigoli delusion, it is credited to the famous Czechoslovakian ballet dancer Frigoli. He used to do this one-leg dance, rotatory dance, and every time he used to face the audience, he used to change his mask. And intermetamorphosis is another delusional misidentification, which you see two people in front of you exchanging their identities. The man is becoming a female and the female is becoming a man. Doppelganger or delusion of doubles, where you feel that there is another person exactly who is a body double of you in this world, who is, into mischievous activities. So these are some of the delusional misidentifications. So just a word, my final slide is about the pathology of delusions. So there are cognitive underpinnings as well as novel neuroimaging techniques which have tried to investigate about what could be the pathology behind delusions. So cognitive theory of delusions have shown that people with delusion make guess based on less evidence. They have a likelihood of changing their mind more rapidly than others. They have more reasoning bias, attentional bias, and attributional bias. They selectively attend to certain phenomena after ignoring certain other things. They selectively reason certain things while ignoring a large portion of the reality. And they attribute certain connotations to a particular behavior after ignoring a large chunk of what it actually represents. So here again, there is a relevance of emotion and theory of mind also in people with delusions. And neuroimaging studies are going on and on and on. Some studies in the initial part of the millennium showed that cingulate gyrus activation was closely associated with persecutory delusions, and entorhinal cortex pathology was closely associated with all positive symptoms, including delusions. But consistent findings have not come in subsequent studies, which could empower us to take an imaging and say that this particular change is there in the brain, so this particular psychiatric illness is likely. We are still a very long way to go in that direction. But of course, the beauty of learning psychiatry is that it is far away from being just like mathematics. And probably that could be the reason why AI is coming and invading into medical practice, but psychiatry most probably is likely to be the last specialty in medicine which is going to be invaded and taken over by AI. Thank you very much for your extremely patient listening.
Thank you so much, sir. It is always a joy listening to your classes. So I think we can take doubts now. I think one is already in the chat box. So kindly give an example of delusion of guilt.
Yeah. Delusion of guilt, we come to situations where adolescents engage in sexual stimulating behavior, like masturbation, very common thing. A person becomes depressed. He doesn't talk to people. He doesn't give face to others. And he doesn't open up what he's actually going through. He attempts suicide. And after he's rescued and brought to a psychiatrist, after a lot of prompting, he opens up his mind and tells that I've sinned, I've masturbated, and God has understood that, and God is going to punish me. So there will be a lot of spiritual, religious connotations to that particular phenomenon, a lot of influence of what we call as Victorian morality. But still, we know from a scientific point of view that masturbation, as WHO calls it, it's the most unhealthy, most healthy method of release of sexual tension. That is what is said. But still, the person feels that he has sinned to God and the God is going to punish him. This is an example of a delusion of guilt. Another question is there any prognostic significance for first rank symptoms? Of course, here again, for first rank symptoms per se, we can't say that there is a prognostic significance. But largely, majority of the first rank symptoms are positive symptoms. And we know from experience as well as evidence that anyone who has got more positive symptoms is likely to respond better to treatment. That is what we know. So, of course, if a person is coming to you with delusions or hallucinations which are very obvious, very visible, we are happy because it is very likely that our antipsychotic is going to work. And if a person is coming with negative symptoms, cognitive symptoms, we know that we have very limited things in our armamentarium. It may take a toll on our uh, clinical practice itself, and it's going to be a long journey out. So, in that sense, of course, we can say that those symptoms can have a positive prognosis. Difference between delusional perception and delusional memory. Again, a wonderful question. So, delusional perception means there is a perception which happens at present, and I attach a delusional significance to it. The classical example I gave is that I am sitting now in a hotel and food has been served to me, and in the bowl which is there, there is a spoon with a crown. I see the spoon with a crown. It's an experience which I had in the present moment. But suddenly I get an idea that they have given me the spoon with a crown because I belong to the royal heritage, royal lineage. So I'm attributing a delusional significance to a perceptual experience which is in the present. Hope I'm clear. And what about delusional memory? Delusional memory is about something which happened in the past. I'm sitting now and telling you that when I was 5 years of age, my father's brother kidnapped me, took me to a particular room, tied me up, and beat me up like anything, and I was traumatized. Such an event has not happened. My parents don't remember, my relatives, none of them remembers, and none of my friends, nobody knows that I have been beaten up at that point of time. But still, I feel, I still, and I strongly hold on to that idea that I have been beaten up like that. So it's a thing of the past. That's it. Frigoli and Capgras once more with examples. Sure. Capgras delusion means a person who is very close to you, like, say, your son. You develop a delusion that that person is not your exact son. Your son has died years ago, and now an imposter. Imposter is the English term for avaran in Malayalam. No? An imposter with a physical resemblance to my son is taking my son's position, and he has got into my house with an intention of poisoning me, killing me, and taking away my property. So that is Capgras delusion. But Frigoli delusion means it is about one persecutor which is taking different forms and shapes. In Capgras, he is taking only one form, that of my son, or that of my wife, or that of my friend. It doesn't frequently change. In Frigoli, a persecutor, a killer, a manipulator, he is taking different shapes and forms. One morning, he is appearing in the form of my father, and he is trying to poison me. I try to evade that situation. I go to my school or college, and suddenly I see the persecutor there standing in the form of my professor. So he's taking different forms and shapes with an intention of killing me. So I hope that is clear. So delusion of ill health versus hypochondriasis. Again, okay. Hypochondriasis is a situation in which you have a very strong feeling that you have got an illness. The example I gave was that I have got a throat cancer. I go to a doctor and specifically complain that I doubt that I have got this illness. I specifically ask for investigations to rule out that illness. And once that investigation is done and the results are normal, I become relieved. I am reassured by the reassurance given by the doctor temporarily for the time being. Maybe after a couple of days, again, I get the same thought. I go to another doctor. I do doctor shopping. I contribute a lot to the development of the corporate health sector of the world. But the thing is that once I am reassured by a particular clinician that all is well, I am relieved for the time being. But in delusion of ill health, I am not relieved by the reassurance of the doctor. I don't believe my doctor at all. I feel that the doctor is telling me lies because he is also part of the system which is trying to conspiring to harm me, the delusional system as we call it. I don't believe. Even after the investigation is done, I strongly believe that no, it is false. I have got an illness. It is that you are unable to diagnose it. That is it. How to differentiate between obsession of ill health and delusion of ill health? Again, interesting question. Obsession of ill health means it's a repeated thought. The example I gave was that rabies. Or maybe I'll give one more example. During the COVID season, a doctor came to me, not a modern medicine practitioner, an alternate medicine practitioner. When he was traveling in bus with a mask, an N95 mask on, somebody coughed in the back of the bus, and he was suddenly getting a thought that is it possible that this virus may travel all the way and get into my nose, and can I get COVID? So here he came to me and he asked me the question. I reassured him that it is very unlikely because the distance up to which a COVID virus can travel is that much. And if you wear a mask, it is very unlikely. I explained everything and he was relieved for the time being. But he returned the very next day to say that after hearing your explanation, which was very convincing, I was relieved. I had a good night's sleep, but next morning I got up and someone in the neighborhood was making loud noise. He was coughing at the top of his voice. Again, I had the same thought. So here again, remember that you are relieved by reassurance, at least temporarily. But if it is a delusion of ill health, you are not relieved. You 100% believe that you have got that illness, and you are not at all relieved by whatever explanation, whatever investigation results, whatever convincing explanation. Even if you are the best teacher in the world or the best communicator in the world, trying to give very clear-cut scientific evidence, the person does not listen to you. He feels that whatever you're telling is absolute lie. He has got that illness. So that's it. Multiple obsessions are also possible in a single patient. How common is this phenomenon in your experience? Definitely, multiple obsessions can occur in the same person, or obsessions can happen one after the other. That is also possible. So many people tell us this history that my son had this habit of excessive cleanliness when he was in 8th standard, but it got cured. And now he is not getting out of the room. He is not talking to anybody. He is not giving face to his relatives. They don't recognize that it is an obsession. Now we ask the boy, and he says that he is getting sexual obsessions of his own mother. He is unable to maintain eye contact with his mother. So it's possible that multiple obsessions can happen at the same time, or obsessions can follow one after the other. So maybe because the more visible or obvious obsessions like contamination obsession with washing compulsion, if they disappear, the parents, the relatives feel that the illness has been cured. But it has not been cured. It has been converted into a more difficult obsession which doesn't have very overt compulsion. So I have seen cases where obsessions and tics coexist, obsessions and ADHD coexist. All these are possible. Can obsession of ill health and delusion of ill health come under a spectrum? Definitely, it can come under a spectrum. Just like gender is a spectrum, sexual orientation is a spectrum, thought processes are also a spectrum. Of course, at one end is a feeling that you're supremely healthy. As we proceed, we can have an overvalued idea that there is something wrong, even especially if there is a family history of coronary artery disease or somebody in your family has died at 40 years of age to myocardial infarction. You feel a little bit unsettled, an overvalued idea. Then later it can evolve into an obsession. And Frank Fish, in some of his earlier papers, had very famously mentioned that obsession, the wall of obsession can crumble into delusion. So now DSM-5 in 2013 agreed that there can be delusion with obsession with poor insight and obsession with delusional beliefs also. So that answers your question. It can be part of a spectrum. Is there any correlation between masturbation and Parkinsonism? Yeah, very interesting question. To the best of our knowledge, to the best of our knowledge, there is nothing like that to be mentioned. But there is more of relationship between masturbation and prostatic illnesses, we should say, because there's a lot of literature available about how if a person is celibate, his chances of developing prostatic inflammation and even prostatic cancers are high. So regular sexual activity, either a consensual sexual activity with a partner or even masturbation, can prevent prostatic inflammation to a certain extent. There is nothing at this point of time to suggest that masturbation precipitates Parkinsonism in any way. How to differentiate OCD with an obsession with poor insight and delusion? Very difficult thing to do, because here again, it is communication and the clarity of communication which matters. If a person with wonderful communication skills develops a psychopathology, he'll be able to clearly explain to you these things. But unfortunately, most of the patients we see may not be so communicative, and some of them might have had already certain cognitive disturbances. When the illness is very chronic, even if OCD is chronic, it can lead to cognitive disturbances, mood disorders also, psychosis also. Sometimes they may become suggestible, they may not give clear-cut answers. But how to differentiate is, it should be an intrusive thought, it should be an unpleasant thought, it should be a repetitive thought to call it an obsession. And poor insight means he knows that it is false, but still, what can I do? I know that this thought is false, but I am helpless in front of it. That is an OCD with poor insight. OCD with but delusion, or OCD with delusional belief, as you call it, it's a situation where a person resigns to this particular thought process, stops fighting with that thought process, does not try to push it out of his system, and lives in accordance with that thought process. One example is, there was this particular lady who was the wife of a very big business person with business interests in 7 different countries in the world, who is confined to her own home for the last 14 years, because she had developed an obsession 14 years ago after her second childbirth. And now it has gone to such an extent that whenever some visitor comes to the home, she wants to wash that particular area in which he sat with 5 different things: a soap, petrol, then some other detergent in a particular order. Now, what has happened is that when the girl child who is in the 9th standard goes to school and comes back, now she takes this girl of hers to the outhouse and cleans her up in a particular order in all these 5 different particles. Now the girl has revolted, and that has led to the consultation. So she is of the belief that this is the only way to get rid of that. It's like a delusion. Difference between OCD and OCPD. OCD, as we have already explained, it's a disorder which has got a particular origin. It started at around 17 years or 19 years or 21 years of age. OCPD or obsessive compulsive personality disorder or anancastic personality disorder, we can't pinpoint the age at which it began. The traits are visible right from late childhood and throughout adolescence, it is present. Perfectionism is the hallmark of OCPD. Perfectionism means you want to get things done in a particular order, and only if things are done in that particular order, it will be successful. No flexibility. Inflexible perfectionism, which is adversely affecting task completion. I can give you an example. In Kerala service rules, so many years ago, there was this particular statement that a government official should have five different pens with five different colors. A particular matter, body of the matter should be written in green ink, the margin should be in black, the heading in certain areas should be red, and the sign should be in green, such things. So OCPD is a person who, if his green pen has run out of ink, will refuse to do anything at all. He'll not sign anything unless that green pen surfaces again. So that is OCPD. Again, is it necessary that a delusional misidentification always has a persecutory reference to it? Need not. Generally, mostly it may have a persecutory. It can have other connotations to it also. It can have erotomanic connotations to it. Sometimes, it is possible that erotomanic connotations or grandiose connotations may also be part of delusional misidentification. Difference between sexual obsession and paraphilia. Again, wonderful question. I'm extremely glad that such brilliant questions are surfacing as part of the discussion. So, in sexual obsession, let me make it very clear, it is a repetitive, intrusive, unpleasant thing. You are having an imagery of your own mother, your own sister, your own brother, or someone very close to you, or even God, and it is producing guilt. You are unable to enjoy it at all. You're feeling guilty, you're feeling disturbed, you're feeling distressed. But in paraphilia, even though on hearing about the paraphilia, the therapist may feel distressed, the client need not feel distressed. He enjoys it. He enjoys it. By definition, there are 8 different types of paraphilias, as we know, starting from exhibitionistic disorder to frotteuristic disorder to fetishistic disorder to transvestic disorder to pedophilic disorder. Different types are there. So even if a person is getting a sexual image of a child, an immature child, he's getting a sexual arousal out of it, he's getting pleasure out of it. So that is paraphilia. In sexual obsession, no pleasure, only guilt. Can the sexual obsession and paraphilia coexist? Again, wonderful question. There have been cases where such things have happened. Like, for example, it started in this way. This particular boy who was engaging in a lot of pornographic material watching right from his childhood itself. He claims that his father used to watch such material and he had a chance to witness his father watching such material. Then he explored and he developed pedophilic impulses to such a great extent. And he was taken to task once because when he was in 12th standard, he tried to sexually assault a 6th standard boy in his own school, and it became a controversy, and some case was charged against him and he was sent for evaluation. So that boy was telling that he was having this images of his own mother, his own sister, but he used to feel intensely guilty about that. And he used to develop an erectile dysfunction also consequent to such visual images. Even though he used to enjoy the sexual images of underage children not related to him, he used to masturbate to those fantasies and he used to act upon those fantasies. Whenever he used to get a sexual imagery of his own mother and sister, he used to feel a transient erectile dysfunction. So that was one case where social obsession and paraphilias coexisted. Difference between made phenomenon, made act and volition, delusion of control, and somatic passivity. Again, this topic is outside the scope of today's discussion, but I'll try to make it as much clear as possible briefly. So, made act means, as Schneider has very clearly mentioned, someone is making me do it. So, this hand is moving because someone is making me do it. That is it. That is a made act. So, delusion of control means my mind is being controlled by somebody. The decisions which I take is being controlled by. And somatic passivity means there is an experience in my body which I am not initiating, I am not voluntarily initiating, it is being controlled by an external agency. Then how tricky is treating OCD with comorbid psychosis? Extremely tricky. There are certain situations where we get dichotomous illnesses which are opposite in nature. Like for example, seizure disorder with psychosis. OCD with psychosis is also another example because a large number of antipsychotics can worsen obsessions. And a few anti obsessional agents can worsen psychosis also. So it goes to be, it is one of the conditions which actually tests the skill of a clinician very much. So there can be situations where we need to opt for medications which doesn't produce obsessions. Antipsychotics, which are notorious to produce obsession, include number one, clozapine, number two is olanzapine. We need to avoid them. We need to go for conventional antipsychotics like trifluoperazine, for example, which may not worsen obsessions. And when we are opting for an anti-obsessional agent, also we need to go for something which has got an action on sigma receptor like fluoxamine, which is less likely to worsen psychosis. That happens to be the combination. So, somatic delusion and tactile hallucination. Again, wonderful question. So, this is again a very commonly asked question for the exam. So, somatic delusion means it is a thought that something is moving in the body, or somebody is touching you, somebody is fondling your genitals. It is the thought which is given maximum importance. While in tactile hallucination, it is the experience itself which is dominant. In certain cases, most